Yes, sir. Three, two, one. We are live now. Yes, sir. We are now live now. We can go ahead.
Okay, just give 5 minutes to join the participants. Join, can you- Sport team, I got a message that the people are unable to join. Can you just have a look?
Yes, sir. Just give me a minute. I am checking.
Any updates, sport team?
Yes, sir. We are working on this. Just allow me a 5 minutes. There is some technical issue glitch. Just give me a 5 minutes.
Okay.
Sir, it's fine now.
Okay.
Yes, sir. Yeah.
So shall we start? Sudhir sir?
Yes.
Okay.
Right. Please start.
Okay, sir. Good evening, everyone, and I welcome you all for this 60th episode of Secret of Neurology. First of all, a huge thanks to our program director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such an incredible web series. It is my privilege to introduce our esteemed course directors, Dr. Sudhir Shah sir. Dr. Sudhir Shah sir is a professor and head of the department at Shrimati NHL MMC and SVP IMSR Ahmedabad, and he is the director of neurosciences at Sterling Hospital, Ahmedabad. A prolific author, and he has written 6 books on the neurology for public education and published the neuro articles in national and international journals also. He is a recipient of India's topmost award, that is a Padma Shri, in 2016 and the Bharat Gaurav Award in 2024. He has also held the BC Roy Award and has been recognized as a fellow of Indian Academy of Neurology, the American Academy of Neurology, and Royal College of Physicians in London. Beyond his impressive list of accolades, he is a recipient of UN Award and the Global Visionary Award. His groundbreaking research on the prolonged fasting and has led to interview with the major international news outlet, includes the BBC and the CNBC, and has featured in the international documentary films also. His primary area of interest is stroke and neurodegenerative disease. Further to this, our another second course director, who is equally more the same category is there, Dr. Lakshmi Narasimhan sir. Dr. Lakshmi Narasimhan sir is a director and professor in the Department of Neurology at Shri Ramchandra Institute of Higher Education and Research in Chennai. He has received the numerous awards, Palliative C Award, A.B. Baker's Award for Global Best Teacher, and from the American Academy of Neurology. He has been a member of Executive Committee, and he is the liaison officer of the World Federation of Neurology. His contribution to the neurosciences are extensive, including the serving an executive member of Indian Academy of Neurology and successfully organizing the 7th consecutive clinical neurological program for DM post-graduation also. Thank you, both of you, immense contribution to the field of neurology, and we honored to have you to lead this series, sir. And I'm not taking much of the time and handing over this session to Dr. Sudhir Shah, sir, to move further, sir. Over to you, sir.
Thank you. Thank you, Mr. Chadda. Well, today is a very important landmark in the webinar series of Secrets of Neurology, Knowledge Feast for All Neurologists. As you know, this is episode number 60, the 60th edition of Secrets of Neurology. So, by this, today we are finishing 5 consecutive years. Every month we have one episode, and it is not only continuous, not only it is full of knowledge, but the content is very well received, not only in India, but across the several part of the globe, in neighboring countries and even in distant countries. There are delegates from sometimes from US, Canada, and Singapore, and of course neighboring countries. So today we are quite happy. Myself and Dr. Lakshmi both, we are filled with joy, pride, and gratitude, everything. And joy is because this is a continuous, without a break kind of series. There are lots of participants. These are all archived episodes, and the students, they really relish the different episodes, and many times they scroll through before going to exams. So this is something which is a wonderful contribution, and therefore I want to thank. So my gratitude is to all the colleges and HODs and the students who have presented the cases. Also, my gratitude to all the delegates who have continuously inspired us and supported us. My gratitude to all, uh, uh, specifically to the team of Globusel division of Celestial division of INTAS, headed by Mr. Chadda. And of course, at a personal note, I am highly thankful to my co-course director, Professor Lakshmi Narasimhan, whose untiring efforts have driven this series to this level. So, thanks to all of you. And today, to commemorate this particular episode, there are two different colleges, and I'm thankful to both HODs and the all the faculty. One is from Government Kilpatrick College, Chennai, who are going to present a case of rapid cognitive decline. That would be done by the student is Evanes Jerome, and associate assistant professor is N. Murugan Ipan, and sorry, Muru Gapandian, maaf karna, the words are slightly Muru Gapandian, Muruga Pandian, and Professor and HOD is Dr. Radha. So the other is the Narayan Medical College, Nellore. They are going to present the case of refractoriness, drug-resistant epilepsy. So the department of Narayan Medical College Neurology is headed by Professor Sampat Kumar, my friend, and the presentation will be done by Ashrita, senior resident, Lipika. I think she's going to present another case, and then Dr. Anusha, assistant professor, will add different dimension, and Dr. Sampath will give concluding remarks. Similarly, Dr. Radha will give concluding remarks, and Professor NM and Ivanus would discuss out the case. So I would not go into more details because we have constraint of time. There are two medical colleges and we have to finish up in time. So once again, I am thankful to all previous colleges and their faculties, and today's both faculties, as well as my co-course director and INTAS, the Celestial Division, for providing uh, unconditional support and networking and everything. So let's have the first case, ma'am. Dr. Radha, kindly take it over.
Fine, sir. Can I ask my PG to thanks for the opportunity given, sir. Good evening, everybody. Thanks for the opportunity given. It's a great privilege to present in this forum, sir. I think we'll justify it also. Can I ask my PG to present the case, sir?
Please go ahead.
Yes, sir. Dr. Jerome to take over.
Good evening, everyone. I am presenting a case of rapid cognitive decline on behalf of Department of Neurology, Government Kilpatrick Medical College. This is a 33-year-old male, Mr. S, who is residing in Tenkasi, Tamil Nadu, who has completed his diploma education and has worked as a ship supervisor in Dubai. Is a right-handed individual. Came with chief complaints of behavioral changes for the past 2 months, seizures 1.5 months back, memory disturbance for the past 1 month. History of presenting illness. Patient while working as a ship supervisor in Dubai.
The slide is visible, Jerome.
Ma'am.
Any problem?
The patient, while working as a ship supervisor in Dubai a year back, lost his job due to knee injury. Hence, he returned to India and was staying with his family. About 2 months back, his wife noticed changes in his behavior in the form of reduced interest in communicating with family members, loss of interest in previous hobbies, anxiety and sadness due to financial stress, no history of hopelessness, helplessness, or suicidal ideas. I'm not able to see my screen, ma'am. Yes.
Support team, can you help him?
Can you unshare first and then again share? Unshare it.
Just stop sharing and reshare it again.
Okay.
Now reshare. Are you able to see?
Yes, sir.
Okay, please.
Uh, 2 weeks later, while talking to his wife, he suddenly stopped speaking and he had a staring look and lost awareness for about 10 seconds. This was followed by tonic-clonic movements of the limbs lasting for 2 minutes, after which he became drowsy. Within 5 minutes, he developed a second seizure, followed by post-ictal confusion, lasting about 30 minutes, for which he was treated in a nearby hospital. He was started on tablet levetiracetam by a physician, and there was no further recurrence of seizures. After 2 weeks, his wife noticed memory disturbances in the form of difficulty in recalling the names of object, but he was able to describe it based on shape and use of the object. He was not able to remember the names of famous actors and politicians, but was able to recognize them with their face and voices. He was able to remember his recent meals and recognize close friends and relatives. He had no difficulty in using objects for daily activities and remained independent in self-care. He never got lost in familiar surroundings. There was no history of disinhibition, aggressive behavior, delusion, or hallucination. There was no history suggestive of cranial nerve, motor, sensory, or cerebellum, or autonomic system involvement. There was no history of fever, headache, vomiting, or neck stiffness. No history of breathlessness, cough and cold, chest pain, or pain abdomen. There's no history of fever with rash, arthralgia, loss of weight, and appetite. There's no history of high-risk sexual behavior. No history of head trauma, recent vaccination. He was evaluated and treated by a neurologist. However, as he did not improve significantly, he came for further management. In past history, he had no history of similar illness in the past. He had a history of right knee ACL tear, which was operated 1 year back. There was no prior systemic comorbidities. Personal history, he was born out of third-degree consanguineous marriage. He has 2 siblings and they are healthy. He takes non-vegetarian diet. He is not an alcoholic or smoker. There is no relevant family history or no similar illness in the family. Treatment history, he was evaluated previously outside with routine investigation, CSF analysis, MRI brain, whole body PET scans were done. He was treated with injection methylprednisolone, 1 gram IVOD for 5 days, and injection acyclovir, 500 mg IV TDS for 1 week. To summarize the case, he's a 33-year-old right-handed gentleman with no prior comorbidities and a negative family history, presented with a subacute onset progressive neurological illness characterized by behavioral changes, focal seizures, non-motor behavioral arrest with secondary generalized tonic-clonic seizures, cognitive impairment in the form of difficulty recalling names of objects and familial persons, with no motor, sensory, cranial nerve, cerebellar, autonomic involvement, or features of raised ICT. In general examination, he is conscious oriented, moderate built and nourished. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. His vitals were stable. MMSE, he scored a total of 25 scores and he lost points in recall and naming. In a higher mental functional assessment, he is a right-handed individual. He is conscious, cooperative, and his emotional status is anxious. Speech and language, in naming was impaired. He had circumlocution. However, comprehension, repetition, word fluency, reading and writing were within normal limits. In frontal lobe assessment, all the tests were normal except he had no insight of his illness. In parietal lobe assessment, both dominant and non-dominant tests were within normal limit. In temporal lobe assessment, verbal memory orientation was normal, repetition was normal. His recent memory was impaired as evidenced by an impaired address and verbal story recall. His remote memory was intact. The occipital lobe functions were within normal limit. His cranial nerve examinations were normal, motor system was normal, sensory system, all modalities were present. There was no cerebellar signs, no signs of meningeal irritation. His gait was normal and spine and cranium was normal. There was no vertebral deformity and tenderness. Other system examination were within normal limits. The anatomical localization, apathy to medial frontal lobe, focal seizures with behavioral arrest followed by secondary generalization to temporal lobe more than frontal lobe. Recent memory and naming difficulty to medial and anterior temporal lobe of the dominant hemisphere. And suspected etiology was encephalitis due to viral or autoimmune and paraneoplastic. His previous investigations done outside were in the CBC, his hemoglobin was 13.5 and a total count of 7,000 and the platelet was 2.3 lakhs. LFT, RFT, electrolytes, thyroid profile, CT chest and abdomen were normal. The first CSF analysis done prior to admission had normal protein, glucose and cell count. The MRI brain report taken showed a T2 altered intensity in the white matter of left temporal, left insular, claustrum and external capsule. It was taken on 26 January 2024. The PET-CT reported a metabolically active enhancing ill-defined soft tissue lesion with surrounding edema in the left temporal lobe, left insular cortex and left external capsule. There was no evidence of metabolically active disease noted elsewhere, and the differentials of infection, metastasis and demyelination were given, and the CA125 correlate was normal. The images of PET-CT. The follow-up MRI brain taken at our hospital had hyperintensity in the right superior frontal parietal white matter and left temporal lobe. There was no significant hippocampus involvement or mass effect. The repeat CSF analysis showed 10 cells with 90% lymphocytes. Glucose was 102, protein 21 milligrams. CBNAT MTB was not detected. OCBs were negative. EG was within normal limits and his viral serology was also non-reactive. The viral PCR for herpes simplex 1 and 2 showed no detection. He was treated with injection acyclovir 10 mg per kg per dose for 3 weeks with the initial 5 days injection methylprednisolone 1 gram IV OD along with anti-epileptic drugs. And his conditions improved and he was discharged with anti-seizure medication. An autoimmune panel was sent and the report was awaited. After 10 days in discharge, he developed irrelevant talk, poor self-care, hypersomnolence. He was not able to carry out his routine daily activities. On examination, he was drowsy with left eye ptosis and abduction restriction. Bilateral fundus examination showed papilledema. He had dysarthria, right facial palsy and right hemiparesis. Higher mental function and lobar test could not be done. Repeat MRI image. It showed a multifocal T2 flare hyperintensity with diffusion restriction in left frontotemporal regions, that is the external capsule, claustrum, insular cortex, perisylvian region, globus pallidus, and right perirollandic and superior temporal cortex. There were additional non-diffusion restricting lesions in right internal capsule, lentiform nucleus, external capsule, and right parietal white matter. And there was a homogeneous contrast enhancement in the left medial temporal lobe, external capsule, claustrum, insular cortex. MR spectroscopy showed low levels of choline, NAA, and creatinine. There was mild prominence of bilateral perioptic CSF spaces. The autoimmune panel from NIMHANS, which was awaited, showed a negative for NMDA, AMPA1-2, Casper2, DPPX, LGI1, and GABA receptor B1, B2. The differentials now were demyelinating disease or a seronegative autoimmune encephalitis. He was again treated with injection methylprednisolone 1 gram IV OD for 5 days, followed by IV immunoglobulin 2 gram per kg. A total of 150 grams were given. He had no significant neurological improvement and he was in admission for the next 1 month. Following a sudden drop in GCS, a repeat neuroimaging was done at the end of the 4th week. And it showed a multifocal T2 flare hyperintensity with diffusion restriction in left frontotemporal regions like external capsule, claustrum, insular cortex, perisylvian region, and globus pallidus, and right perirolandic superior temporal cortex. There are additional non-diffusion restricting T2 flare hyperintensities in right internal capsule, lentiform nucleus, external capsule, right parietal white matter, genu, and splenium of corpus callosum. In contrast, it had a homogeneous enhancement in left medial temporal lobe, external capsule, claustrum, insular cortex, and a patchy enhancement in the right parietal lobe. And there was a mass effect in the form of effacement of left lateral ventricle with 5 mm rightward midline shift. And other changes were T1 shortening in the left lateral temporal lobe, which suggested a cortical laminar necrosis, and a T2 flare hyperintensity in the left midbrain, thickening and enhancement of left fornix, and involvement of optic chiasma and left optic tract. And the MR spectroscopy now showed an elevated choline and a lipid lactate peak, and a possibility of tumefactive demyelination was considered.
Jerome, can you please show the MRI plates properly? Yeah. Let people see MRI. Okay.
Show in sequence, Jerome.
Sir. This is the first MRI that showed a left temporal hyperintensity with hippocampal enlargement. And the next one taken 1 week later had additional lesions in the right frontal and parietal lobes, and the left temporal lobes persisted with no mass effect. And 1 month later, MRI showed a multifocal bilateral lesions with the left medial temporal homogeneous contrast enhancement, and the MR spectroscopy showed reduced choline, creatinine, and NAA peaks. And 1 month later, when his GCS dropped, the MRI showed a mass effect with midline shift, and there was cortical laminar necrosis and involvement of optic pathway and new lesions in corpus callosum. The MR spectroscopy showed increased choline and lipid lactates. Following this, neurosurgery opinion was obtained and suggested brain biopsy. The patient bystanders were not willing for invasive procedure at that time. The antibody panel for demyelinating disorders was ordered, and MOG turned out to be mild positive in serum, and aquaporin 4 was negative. He was treated with injection rituximab 500 mg. 2 doses were given 1 week apart. This shows the MRI progression in timeline. The first MRI, the second MRI, the third MRI, the last MRI. The diagnosis of possible cerebral cortical encephalitis under Mogad spectrum disorder was considered.
Sir, the case was presented for different presentations, and initially Mogad was not in our list at all, sir, actually. So initially what we thought of was chronic herpes encephalitis. That was our first diagnosis, as the patient came from Dubai with a lot of behavioral disturbance and seizures. So it was our first diagnosis actually. And the second one, we thought of, since the HSV came negative, we thought it could be an autoimmune encephalitis. So we treated it accordingly with steroids and IVIG. Initially in the first phase, actually the patient responded well to steroids during the first phase, sir. After which he was symptom free for a period of at least 3 weeks to 1 month. Later he came with the recurrence of all the disease. And second time, when we started him on IV methylprednisolone, there was not much improvement. So we started him on IVIG as well. But he hasn't showed much improvement. Rather, he showed a minimal improvement. And for after a period of 3 to 4 weeks, he again descended back. So he had a disturbance with raised ICTs, and the patient was developing papilledema, abducens palsy, ptosis, and the patient was also having a focal neurological deficit, and the disease course was progressive. So we had difficulty in diagnosing, and autoimmune panel also came negative. And we had a light of vision from our third MRI, sir, which showed a cortical laminar necrosis, which is more suggestive of a demyelinating disorder rather. And this presentation for a demyelinating disorder is bit rare according to us. So to enlighten this, we needed to present the case. The other differentials in our list was CNS lymphoma, for which only biopsy was ordered. Since the patient's attenders was not actually willing for biopsy, and we couldn't go further. And if it is going to be a biopsy also, and if it is going to be a CNS lymphoma also, the response to steroid should be further better, sir, definitely when compared to other diseases. So CNS lymphoma also goes down in the list. After seeing the tumefactive demyelination like picture and laminar cortical necrosis, we went ahead with the demyelinating panel, sir. Otherwise, we wouldn't have done. We didn't expect such a course in a demyelinating disorder. And so we proceeded with the MOG antibody panel. It came as mild positive as expected because the patient was on both steroids and IVIG also. So naturally the antibody level would have come down. Otherwise, if it have done in the first instant, possibly it would have been high. So we took the explanation as such, and then we proceeded with rituximab. And with rituximab, after receiving the second dose, the patient succumbed, sir. We couldn't save the patient actually. So this cases was presented actually to the panel to share others' experience regarding this kind of disorders like MOGAD presenting as focal cortical cerebritis, which is in fact a rare one, sir. When compared to other presentations of MOGAD like optic neuritis, transverse myelitis, ADAM, and brainstem cerebellar involvement. We like to hear from the audience also, sir, regarding their opinion and what other differential diagnosis could have included in the list and what we have missed also. Thank you, sir.
Dr. Lakshmi, are you available to comment? Professor Lakshmi? There was
I'll
one
call him.
MRI showing optic chiasma involvement. Can you show me that again, third one? Yeah, optic pathways. Yeah. You have any MRI of the spine also? Orbit
Spine
and
screening was done thrice, sir. It was normal.
You're absolutely right, madam, that focal cortical encephalitis is not a common presentation of MOGAD or this NMO group of disorders. But in literature, if you see now, we see good number of such cases. So I think we have also made it a practice to involve
MOGAD also in the list, sir.
MOGAD antibodies and NMO screening in all such patients who have so demyelination certainly comes as a differential diagnosis of this kind of rapidly progressive disorder with fluctuations and changing sites and all that. And after all, the spectroscopy findings also probably favors that one could think of some kind of demyelination. And CSF also showing a little of cells and all. So my
Not much
question,
focusing on infection, sir. Initially, we thought of infection only. Later that we moved on to autoimmune. And then only even paraneoplastic we thought of. So only the PET was done actually. It was done previously itself, sir, when he came to us actually. So that category went off actually. After seeing the tumefactive changes and mass effect only, the demyelinating MOGAD picture came into the actually came into picture. Later only we did, sir. So otherwise we wouldn't have done because we don't expect much of a gray matter involvement at the presentation for a demyelinating disorder.
Does
in MOGAD you sometimes see this, and that is now
Mixed presentation.
appearing in the literature quite well. And
Dr.
I
Radha,
understand this is a very unusual presentation and very fast progressive course. But certainly it reminds us that in such kind of situation, we should certainly consider MOGAD and other autoimmune conditions where you don't find autoimmune encephalitis present, panel coming up positive. So autoimmune, one thing, vasculitis, another thing, encephalitis and other infections is another possibility, but certainly we should not forget demyelination. For paraneoplastic, it is too rapid and too much changing, and of course we can always keep that in mind, but I would put it clinically a little lower on the card. So we should do more and more MOGAD screening in patients with this kind of presentation and MRI findings. So I think your point is well taken, and it was nice that you presented this case and
Dr. Lakshmi is
served the
next now.
purpose. Yeah.
Yes. Biopsy could have helped, sir, definitely to differentiate it from other lesions. But since it's in the brain and patient's attender were not willing for invasive because he was with us for more than 2 months in the ward. And we asked them in the end, sir, so they were bit hesitant to disturb him also. So they were not that willing. And considering audience questions for EEG changes, there was a slowing only, sir. There were no plates as we expected, and there were no delta spikes suggestive of autoimmune encephalitis. And slowing was there actually in the temporal region in the repeat EEG. And regarding false positive MOGAD, we also thought of the possibility of false positive MOGAD also, sir. But the MOGAD levels can go down when the patient is on steroids and also on IVIG. Mainly on steroids, sir. In IVIG also, sometimes it may show a false increase. So the possibility of false positive MOGAD cannot be ruled out in this case, sir. Since we have no other thing to attribute it, we took MOGAD for our consideration, and we thought it could be a focal cortical cerebritis to label him a disease at least. And our learning from this is demyelination can have multiple presentations. And if there is a tumefactive change, I think we need to go ahead with MOGAD and also use rituximab in escalating doses to save these patients.
Somebody has asked why there is increased colon peak.
Sir, possibly because of the cortical laminar necrosis, sir. The deeper regions of the tumefactive demyelination can go in for necrosis and they can have a colon peak, sir. It behaves as if like a tumor, so only it's called as a tumefactive demyelination.
Or some other infective condition like Lyme.
Sir, neuroborreliosis we didn't think of, sir.
Yeah. All right.
Dr. Radha, thank you for an excellent presentation.
Thank you, sir.
And the MOGAD has now become a real masquerader of many things. Whenever there is a cortical and subcortical, in fact, it looks it looks like an ADAM mimic also. Not only a tumor mimic, it also looks like an ADAM mimic nowadays. And in fact, we recently had a case shifted from Madurai, extensive cortical, subcortical, and a lengthy spinal lesion. Turned out to be very strongly MOGAD positive. So, thanks for a wonderful case.
Thank you, sir.
Very well presented by Ivanas Jerome, and in fact, the PET is so angry. Very high intake of PET sayings showing that today. In fact, I was reading about one of the colon peak in MR spectroscopy. Colon peak points
and
out that it is a tumefactive demyelination because of it. And second thing is, whenever you look for a colon peak means just a cell turnover.
Yes, sir.
We use colon peak in MR spectroscopy to assess remyelination. After when you follow up of the case, MR spectroscopy is used for checking up remyelination. Today, in fact, we had a discussion in ECTRIMS on this. So remyelination also, for the sake of students, you should use presence of choline peak for remyelination as a follow-up of cases. Okay, and one other comment in the box there is a NMO positive spinal lesion turned out to be glioma at a later point of time. So that is also a comment. And thanks for a wonderful case. Thank you. Thank you.
Thank you,
Yeah,
sir.
that is not uncommon. NMO people have astrocytoma, and because of after all, it's cytopathy, so you can get expanding lesions, and some of them turn out to be not very common, but it is not uncommon. And at the same time, I was wondering, Dr. Radha, what do you think? Why we lost the case? What must have happened? After rituximab, something happened, or?
No, sir. He was actually having a raised ICT and was on ventilator, and he succumbed to ventilator-related infection also, sir.
Oh, okay. I see. So total duration of illness at your place was how much?
Sir?
How much was the total duration of illness at your institute?
It was around 2 months, sir.
Okay. I see.
The entire course was within 3 to 4 months only, sir. He was there with us for more than last 1 month. He was continuously with us. Previously, he used to come and go. After first steroids, he went home and he came back for admission.
Thank you. I think so we have,
last
we have one more
question is, sorry, doctor, why you selected the title Rapid Progressive Cognitive Decline as the title of this case?
Sir, actually, we presented 2 sets of cases, sir. One this and the other one was CJD while having in our previous presentation. Possibly my PG would have included the same topic for this case also, sir.
Okay.
And again, it's
Okay,
also a
all
case
right.
of rapid cognitive decline in front of our eyes, sir.
Right.
Thank
Multiple MRI lesions or fluctuating MRI lesions in brain, something more catchy
Yes, sir.
in this particular case. Yeah.
But even
Anyway,
that
thank
case,
you
no,
for
sir, with
this wonderful
CJD,
case.
it also present. Yes, sir.
This was a really nice case. It is a reminder to all of us that we should always keep MOGAD as a differential diagnosis. And Dr. Lakshmi said MOGAD is one of the differential diagnoses of EDEM. That thing is very important to understand. All right. So you have one case only, ma'am?
Yes, sir. One case only, sir.
All right. So thank you once again. And
Thank you, sir.
may I now request Dr. Sampath Kumar to have your presentation, please.
Very good evening, sir. First of all, thanks to our teachers, Mr. Shaw sir and Lakshmi Narasimhan sir, and special acknowledgements to INTOS for allowing to take part in these presentations. So the topics which you selected to unravel the refractoriness of a resistant epilepsy. So any case patient is not responding of an epilepsy case, 2, 3, 4 drugs and all, we always look into the imaging, what will going to do happen to the lesion. But sometimes, no, I think you'll find multiple lesions which account for the refractoriness. So it is a clinician has to look on the semiology, of course, take the advantages of video EEG and functional imaging, all the factors. So by what is the responsible for the refractoriness? To show the case, we have 2 case presentations, which clearly illustrates how to focus the lesion. And if you focus the lesion, how to go ahead with the non-pharmacological managements and all. So the first case, I think Dr. Asrita will going to take up. Dr. Asrita.
A very good evening, one and all. So, myself, Dr. Asrita, neurology resident from Narayana Medical College, and my moderator, Dr. Sampath Kumar, head of the department, and Dr. Anusha ma'am, associate professor. Here is the case. A 24-year-old male patient born to second-degree consanguineous parents prematurely at 7 months of age. with normal birth history and no developmental delay and with no comorbidities, presented with history of seizures. The age of onset of seizure is at 15 years of age, and seizure types were one is focal and the second one is focal with secondary generalization. The semiology of first seizure is first episode started as sudden jerk-like movement of upper limb followed by abrupt fall while riding bike, and he got up immediately without any loss of awareness and with no history of post-ictal confusion. And these episodes were lasting for few seconds and occurs at a rate of 3 to 4 episodes per day. And frequency gradually increased to 10 to 12 episodes per day in the last 2 to 3 years. And these episodes were seen both in awake state and also during sleep. And because of this, he had multiple episodes of falls and trauma. And the second semiology is focal to secondary generalization, which started with aura, started with tingling of left upper limb lasting for 1 to 2 minutes, followed by the ictal phase, that is tonic-clonic jerks lasting for 1 minute, with a post-ictal confusion for 5 minutes. And there was only one such episode noted so far. And he was on multiple drugs, that is on tablet phenytoin, oxcarbazepine, levetiracetam, lamotrigine, and on clobazam. And coming to the past history, he has no history of any childhood seizures, meningitis, chronic illness, or any head trauma. Family history is nil significance, and his drug compliance was good. And this is the seizure we were mentioning too. He was having asymmetric tonic limb posturing with right upper limb inflection at elbow joint and left upper limb outstretched or extended. And examination, his higher mental functions, cranial nerve examination, motor system, sensory system, cerebellar was normal with no involuntary movements. And his routine blood workup, that is complete blood picture, RFTs, LFTs, random blood sugar, electrolytes was normal, and screening is negative. And coming to the imaging, this is a FLAIR image showing high signal at the right middle frontal gyrus, along with the cortical thickening, as we can see in the coronal view. And this was the MRI brain report, likely focal cortical dysplasia in the right frontal lobe. This is the video EEG recording of the patient. As we can see, the lead started in the right frontal leads, but seen bilateral frontocentral leads predominantly on the right side. And also this correlating with the semiology of the seizure in the video EEG. And video EEG was suggestive of focal spike and wave discharges seen in bilateral frontocentral regions, predominantly on the right side. And this was the PET-CT brain report showing mild hypometabolism in the right sensory motor and bilateral medial frontal cortices. This is the MRI and PET image fusion done in neuronavigation system and FCD with hypometabolism exactly identified. And pre-surgically neuropsychological assessment was done, which was indicative of global involvement. To summarize the history, a 24-year-old male presented with focal motor seizures characterized by flexion of right upper limb and extension of left upper limb, resulting in a fencing posture or figure of 4, preserved awareness during seizures. Localization is probably right supplementary motor area of the frontal lobe. And according to classification, it comes under focal motor seizure with consciousness, which was previously known as simple partial seizure. And from this, we came to a diagnosis of right frontal FCD with intractable seizures. And this patient was taken up for surgery. Awake right frontal craniotomy with excision was planned under electrocorticography and neuronavigation guidance. Right frontal FCD involving posterior part of middle frontal gyrus, just anterior to the hand knob area of motor cortex identified, and electrocorticography spikes recorded from the cortex near the FCD, just anterior to the motor cortex. With depth electrode recording, spikes recorded from the depth of sulcus of FCD. And continuous monitoring of motor power in the left upper limb and lower limb was being monitored while operating. Lesion excision was done completely under neuronavigation guidance. Post-resection electrocorticography recording showed no evidence of spikes in the cortex surrounding the resection cavity. And biopsy sample was sent, which was suggestive of MOGE, that is mild malformation of cortical development with oligodendroglial hyperplasia, right frontal region.
Fine. Dr. Asrita, I think this is the one case.
Yes, sir.
We'll proceed with second case. Then after two case presentations, we'll go with discussions. What is the points? What are the things which we really happens to carry home messages to the audience? The next
Sure.
case, I think, goes to Dr. Lipika.
Yes, sir. Thank you, sir.
Good evening to all respected faculty, seniors, and my fellow colleagues. I am Dr. C. Lipika, Senior Resident of Narayana Medical College. My moderator is Dr. Sampath Sir, Professor and Head of Department of Neurology, and Anusha Madam, Associate Professor of Neurology. My topic is a rare case presentation to unravel the refractoriness of drug-resistant epilepsy. I'm going to present regarding a 18-year-old male patient who presented with seizure-like activity since 12 years of his age. Birth history: he is a firstborn child of non-consanguineous parents by normal vaginal delivery with immediate cry at birth. His birth weight is 3.5 kgs. No seizure activity is observed at birth. Birth history is unremarkable with no indicators of perinatal hypoxia or insult that might predispose to the epilepsy. Development history: there is significant developmental delay in the form of motor developmental delay. He has achieved walking at the age of 24 months, and speech development, there is delay in speech development where he has attained after 3 years of age. These developmental delays may suggest an underlying neurological condition or early brain insult that could contribute to the epileptogenesis. Family history: there is no family history of seizure. The absence of seizure act with the family members suggests that the patient's epilepsy is likely not genetic in etiology. It can be potentially acquired or structured in nature. It can be related to early development or acquired insult. This finding that takes clinical attention towards identifying structural abnormalities as a part of epileptogenic focus rather than genetic testing, although sporadic genetic mutations cannot be ruled out. Coming to the antecedent event, patient developed first seizure episode at the age of 1 year. He has experienced a single provoked seizure in the setting of a fever characterized by bilateral upper and lower limb tonic-clonic movements followed by uplowering of eyeballs and associated with frothing. He was diagnosed with meningoencephalitis, which is an inflammatory condition affecting the brain and meninges. He was initiated on anti-epileptic medication as a part of treatment protocol. At the age of 1 to 2 years, he is treated with anti-epileptic drugs for 1 year, following which he stopped the drug after 1 year. He was seizure-free period for approximately 10 years after discontinuation of the anti-epileptic medication. Again, the seizure reoccurred at the age of 12 years with different semiologies. This clinical trajectory: early provoked seizure, followed by a prolonged seizure-free interval, then later recurrence of different seizure semiologies, suggest a potential epileptogenesis during the latent period, which is usually observed in post-inflammatory or post-insult epilepsy. Two different semiology types are noted. The presence of two distinct semiology types suggests either a single epileptogenic zone capable of producing different seizure patterns or multiple epileptogenic zones. This complexity is often observed in drug-resistant epilepsy and requires careful analysis for appropriate surgical planning. Coming to the first seizure semiology, it usually occurs while eating. There is no hora. The interface is characterized by head drop with head deviation sometimes to right and sometimes to left, with behavioral arrest, oral automatisms, and occasionally secondary generalization is seen. It is associated with post-ictal nose swiping, sometimes with right and sometimes with left upper lip. After taking consent from the patient, family members, and the patient, we have kept the video. We can see that while eating, patient developed head drop with behavioral arrest. With nose swiping with the right upper limb. With chewing movements, oral automatisms are seen. This is another video. Head is deviated to the right side with behavioral arrest. With impaired awareness and oral chewing movements are seen. With nose swiping with the left upper lip. Coming to lateralization and localization, post-ictal nose swiping is usually seen in the ipsilateral side. In this patient, it can be either right or left-sided. Oral automatisms localized to opercular region, behavioral arrest localized to mesial temporal lobe, and secondary generalization is consistent with the temporal lobe origin, which has a tendency to propagate and generalize. These semiological features collectively suggest either right or left hemispheric focus involving both the opercular and temporal regions, consistent with the concept of temporopericilvian epilepsy. Second semiology, patient, there is no aura with interface of left upper limb dystonic posturing with forced head deviation to left side, followed by tonic-clonic movements of all four limbs, uproaring of eyeballs, and loss of awareness. Post-ictal drowsiness and confusion is present. This is other video showing the second semiology. There is dystonic posturing of the left upper limb with deviation of head to left side, followed by tonic and clonic movements of both left and right upper limb with secondary generalization to all the four limbs. The lateralization and localization for the second semiology is left dystonic and posturing will lateralize to right hemispheric involvement, whereas the left head deviation will lateralize to right hemisphere and localize to the frontal eye field or premotor cortex. Coming to provisional diagnosis, it is a reflex eating epilepsy. Right opercular involvement explains oral automatisms during seizure, which is consistent with eating triggered seizure, which is a part of pericervical region critical for orofacial function. Right temporal lobe involvement, the favoring points are antecedent event, automatisms, arrest, associated with propensity for secondary generalization. Head deviation during seizure before secondary generalization points towards right frontal lobe involvement. Based on semiology analysis, both seizure types appear to originate from the right hemisphere, specifically involving the opercular, frontal, and temporal regions, suggesting a temporopellicervian epileptogenic network. Seizure frequency are about 3 to 5 per day. Patient experienced multiple seizures. More than 50% of episodes occur during or within the 30 minutes of eating breakfast, lunch, or dinner each day, despite anti-epileptic medication. This high seizure frequency, despite multiple anti-epileptic medication, meets the criteria for drug-resistant epilepsy, defined as a failure to achieve seizure freedom with adequate trials of at least 2 appropriately chosen and well-tolerated anti-seizure medications. Drug is to include levetiracetam of 1000 mg 3 times a day, that is 3000 mg per day, lacosamide 200 mg twice daily, which is 400 mg per day, and clobazam 10 mg once daily at night. Despite treatment with more than 2 appropriate anti-epileptic medications at adequate dose, the patient continues to have multiple daily seizures, confirming drug-resistant epilepsy according to ILAE 2025 criteria. On examination, general examination, there are no neurocutaneous markers. Higher mental function is oriented to time, place, and person. His MMSC is 17/30. Cranial nerve examination is normal. Motor system examination, sensory system examination, reflexes, and cerebellar function is normal. Coming to laboratory investigations, is hemoglobin, leukocyte, platelet count is normal. Blood serology is not suggestive of any viral infection. Biochemistry results shows electrolytes are normal, and metabolic parameters like sugars and RFTs are normal. Electrolyte disturbances can lower the seizure threshold or mimic neurological symptoms, but this patient's values are within normal range. Metabolic parameters is also normal, indicating no renal dysfunction or glucose abnormalities, which can complicate the management. Additional laboratory tests like coagulation profile, liver function tests, and protein studies are also normal. MRI brain is suggestive. We can see that there is a hyperintensity in the right pericerebral area, which correlates with the semiology, including the eating trigger seizures and oral automatisms. This is T2 coroner section, which shows significant right hippocampal atrophy. There is volume loss of right hippocampus compared to left side, and gliotic changes are also noted in the right mesiotemporal structures. We can see around the sylvial circus at the parietal operculum, temporal operculum, and near the insular cortex, there is gliosis associated with MTS. So the MRI report is suggestive of right mesiotemporal sclerosis with significant volume loss and gliotic changes in the right mesiotemporal lobe and temporo-occipital lobe. Video EEG, the interictal abnormalities, there is multifocal epileptiform discharges of right more than left centroparietal temporal region with tangential dipole pattern, that is frontal positivity and temporal parietal negativity. Generalized epileptiform abnormalities are suggestive of secondary bilateral synchrony. In ictal events, there are 2 focal to bilateral tonic-clonic seizures recorded. Diffuse onset with right frontotemporal predominance. The conclusion is symptomatic localization related epilepsy of right pericerebral origin. The video EEG correlates electrical cranial activity with clinical seizure manifestation, confirming the epileptogenic zone localizing to the right temporopercerebral region, which is consistent with the structural abnormalities identified on MRI. We can see that there is a tangential dipole, that is the frontal positivity and temporal negativity. Here also we can see tangential dipole. Coming to PET scan. PET scan is suggestive of significant hypometabolism involving the right superolateral and right infralateral anterior temporal cortices. Also, there is moderate hypometabolism involving the right sensory motor and the right parieto-temporal cortices, possibly functional deficit zone. Coming to neuropsychological assessment, its score is 10/15, which is indicative of deficits in global cognitive function. Coming to the neurosurgery, procedure type that was done was right frontotemporal awake craniotomy with excision of the right periinsular gliosis under neuronavigation guidance. It is done under general anesthesia with awake component for functional mapping on March 27, 2025. Awake craniotomy was selected to follow the functional mapping during the procedure, minimizing the risk to eloquent cortex while maximizing the resection of the epileptogenic zone. Neuronavigation guidance provided precise anatomical localization during surgery, integration preoperative imaging for real-time surgical navigation. Intraop electrocorticography recording from the exposed cortical surface revealed spikes from inferior frontal gyrus and superior temporal gyrus. Surgical excision included the superior temporal gyrus, inferior frontal gyrus, frontal operculum with gliosis, and complete excision of the periinsular gliotic tissue. Functional monitoring, that is continuous monitoring of the motor function in the left upper and lower limbs, were done during the resection. No neurological deficit detected at the conclusion of the procedure. Post-resection, there is showed absence of epileptiform spikes in the tissue surrounding the resection cavity. This finding is highly predictive of favorable seizure outcome following the epilepsy surgery. Complete removal of epileptogenic tissue is the strongest predictor of post-surgical seizure freedom. Intraoperative electrocorticography helps us to ensure that the epileptic zone has been completely resected. Histopathological findings are suggestive of gliosis in the superior temporal gyrus, temporal pole, and inferior frontal gyrus. Coming to my key takeaways, precise localization of epileptogenic zone requires concordant data from multiple modalities like detailed clinical history and seizure semiology, high resolution structural MRI, video EEG monitoring, functional neuroimaging like PET scan, and neuropsychological assessment. Early identification is necessary for surgical candidates. Thank you.
Hello. My hearty congratulations. 2 classical cases with concordance in clinical, electrophysiological.
Yes, just to highlight.
All absolutely concordant and healing. So, in fact, both the presenters, Ashrita as well as Lipika, they presented excellently well. And you should know it's an eye opener for the residents how to work up the pre-surgical workup of the various modalities, how you work up for the case towards localization of the seizure onset zone and defining the seizure propagation zone, and discussion with the neuropsychiatrists with a good clinical psychometry and surgical planning, and meticulous surgical planning will really result in very good results. Choosing the case is the real challenge in all these refractory epilepsy cases. My hearty congratulations to Sampath and his team. Thank you. And sir, any questions from 1 minute? I just one in the.
Just wondering, what
was there
the
any
follow-up of
question?
No, Lakshmi sir.
Yes, sir. There's one question in the chat box. Was there any hemispheric atrophy or hemiparesis clinically?
Yes. So thank you, sir. I think just our purpose of presenting these 2 cases is any case which is drug refractory. One thing is, I think people should know how to work up and how to localize the lesion and lateralize the lesion. We have localizations in neurology practice nowadays. It's become very fashion per passion to localize and lateralize the lesion in epilepsy, because localization is the most important thing, which is guided by semiology, to concordance with video EEG electroclinical, and take the help of PET, especially to look for the hypometabolism, especially when you're dealing with the areas which are very close functional eloquent areas, and to take up the surgery, which is most concordant lesion is there, the surgical outcomes are good. So these 2 cases which we have really taken up is, the first case, if you take the money, the localization is corresponds to go to the right superior, like supplementary motor area, which corresponds to the video EEG findings, which is proven in video PET scan also. Surgery awake granite was done, but post-operatively, patient has developed same day some cortical hand phenomena. Subsequently, patient is not responding adequately with post-surgical operation also, even though there is a concordant lesion. The reason being, the post-surgery epilepsy surgery outcomes also depends upon the not only localization concordance, it also depends upon the pathology, because the pathology which has come to is not only focal cortical dysplasia, it is a pathology something like a Moge, which is a pathology which is very classical. I think Dr. Anusha, highlight what is a classical Moge, why patient is not responding, what is the behind things which we learn after going through the pathology report. Dr. Anusha, I think you can share and give some conclusions on Moge pictures.
That was my question to you. Okay, what is the outcome of both the patient? Because when you said is Moge, I was wondering what was happening to this patient.
That's the reason. I think we have shown the well localization and well procedure and all, but patient post-operatively is not doing well.
Yes, that's very critical to know that. Yeah.
Because even though localization was very, very precise and operation was well executed, but post-surgical surgical results are not good. It's all because of pathology. So even though localization, everything is concordant, sometimes post-surgical results are very, very bad. And sometimes pathology will guide some other management aspects after seeing the pathology. To reveal that thing only we presented this case. I think that Anusha, you can show the Moge pathology and what things are.
Good evening, sir. So today I'm discussing about this Moge and eating epilepsy. Moge is mild malformation of cortical development with oligodendral hyperplasia in epilepsy, and it is a newly recognized clinico-pathological entity. Before, it was first recognized in 2017. Before these Moge, who are drug resistant, the biopsy specimens, they were thought it as focal cortical dysplasia, but due to some findings in that histopathology, they have recognized it as a Moge. It is associated with drug-resistant epilepsy, and it is very difficult to detect on MRI, and it is amenable to neurosurgical treatment. And the presentations of Moge are highly variable. They can present as epileptic spasms, tonic-clonic seizures, hyperkinetic seizures, and they may present as cognitive impairment. Due to the overlap of phenotypes, it can be easily misdiagnosed as focal cortical dysplasias or epileptic encephalopathies before surgeries. The histopathology is characterized by oligodendroglial hyperplasia. There's an increased number of oligodendral glial cells in that area, and there would be heterotopic neurons. Normally, the neurons would be found in the cerebral gray matter, but if the presence of neurons found in the white matter rather than the gray matter, that indicates that's one of the histopathological characteristic of Moge. And there would be hypomyelination with the patchy areas of reduced myelin is seen, and there will be blurred boundaries. That's a blurring of normal distinction between the gray matter and white matter is seen. Here is the histopathological slides where in A and B you could see that there is a blurring of gray matter and white matter. In the slide C, you could see the heterotopic neurons which are seen in the white matter, and the D there you could see the oligodendroglial density, increase in oligodendroglial density. The pathogenesis is it's linked to the somatic mosaic variants of this gene SLC35A2, which it is encoding a UDP galactose transporter. This helps in glycolization normally. If there is a genetic mutation in this gene, it causes disrupted glycosylation. This impaired function of this transporter, it leads to the defect in protein glycolization, which is very crucial for brain development and function. And this leads to malformations during the brain development. Here in this picture, you can see, and it's a normal SLC35A2 function. There would be in this Golgi apparatus, this protein which encodes this receptor SLC35A2. It causes a transport of UDP glucose from cytosol to Golgi apparatus, which causes it makes a glycosylated protein. When there is a loss of this function, there is an abnormal glycolization, and this function of protein does not occur, and there you can see a Moge features, histopathological features in the brain. And this causes a combination of these histological features causes highly epileptogenic area, leading to refractory focal epilepsy. It's seen mainly in the frontal lobe, but it's not only in the frontal lobe. This can be seen in other lobes also. So this is an article which is published in 2017. It is recognized as a new clinical pathological entity. Here they have dissected 1381 patients who had refractory epilepsy. They have found that 52 patients, that's 3.7% of cases, they could not be classified histopathologically as focal cortical dysplasia or other malformation, and they were labeled as non-lesional. But on re-evaluation of these cases, at 42% of those 52 cases, they have seen there is increase in oligodendroglial in white matter, and also there are heterotopic neurons. So they have said these non-lesional cases as Moge, and they coined the Moge term to describe this new entity. And there are also heterotopic neurons. They were found in subjacent to corticomedullary junction, but not in the deep white matter. It differentiates it from MCD, malformations of cortical MCD, which is Palmini type 2. And these dysmorphic neurons, balloon cells and dyslamination, they are absent, which are seen in focal cortical dysplasia. And there is an absence of inflammation and neuroepithelial tumor infiltration, which are characteristic of Moge. So in Moge, we find this increased oligodendroglial cells and heterotopic neurons, but not inflammation. And there's also one more article which shows that the temporal lobe plus epilepsy is associated with Moge, but it's not in the frontal, but it can happen in other areas also. Here, they have described 2 patients with temporal plus epilepsy and biopsy-proven Moge, demonstrating it need not be limited to the frontal lobe. But in our case, it was limited to the frontal lobe, and it did not involve any other lobes. So the findings of this presence of this variant in this case of Moge, it also promotes the development of precision therapy. There were 2 articles. This they showed that there is a clinical improvement in response to oral D-galactose supplementation in these patients. This results in reduction of seizure frequency. So this galactose supplementation may partially increase cytosolic UDP galactose. This facilitates galactolization through alternative UDP galactose transport into the Golgi apparatus. So this is very important to evaluate this therapeutic approach in this patient. So for whom the surgery is not an option or a surgery has failed to reduce seizures, the administration of D-galactose can offer a personalized treatment strategy for precision therapy. So here, the operative outcome was good, but after 2 to 3 months, again, patient presents with the same seizures. So this says that there is a pathology that is due to pathology, that is due to Moge. So this says that even the excision of complete epileptogenic zone, so these seizures are refractory. So next discussion is regarding the eating epilepsy. So this is eating epilepsy is a rare disorder characterized by reflex seizures induced by food intake. And it includes patients who had more than 50% of seizures during or within 30 minutes of eating. It usually begins in second decade of life, seen in males, seen mostly in the South Asian origin. And the symptomatic causes and also genetic factors also play a role. In symptomatic factors, cortical malformations, of cortical development and tumors, mesotemporal sclerosis could be present. Genetic factors, there are some chromosomal conditions like Reduchat syndrome, Rett syndrome, as SYN gap mutations and possible potassium channel mutations variants are involved. The pathophysiology is, it is due to interaction between a temporal lobe and amygdala, as the temporal lobe is closely related to amygdala, connected to amygdala, which has a lower seizure threshold. It has propensity to trigger the masticatory seizures, which explains why the oral stimuli may provoke the seizures. And there are also some patients who experience seizures which they are triggered by sight of food or sensory cues. This says that there is a temporal lobe pathways which are connected to olfaction and taste perception. There are also some critical cortical loops which are likely involved, like gustatory cortex loops and frontal opercular loop. Gustatory cortex loop involves insular, parietal, and frontal regions which have a strong network, frontal, insular, hippocampal network, and also frontal opercular loop which are related to oral and masticatory control. So in patients with cortical developmental malformations, repetitive stimuli such as eating can cause pathologic hyperactivation. It is due to the hyperexcitability secondary to the underlying structural lesions. So the syndromes where there could be two clinical syndromes which are associated. These are temporal limbic onset or extra limbic onset seizures could be present, and they experience 52% experience exclusively while eating. Only 5% have seizures towards the end of the meal, and the types of seizures would be focal impaired seizures or GTCS, and EEG shows epileptiform discharges from mesial temporal lobe structures. This also, it needs polytherapy in 60% of patients, and over half of the patient report less than 50% of seizure control. Of them, 16% are drug resistant, and it involves a surgical treatment or vagal nerve stimulation. Thank you.
Excellent, Dr. Anusha. Excellent. Really enjoyed. Thank you.
So just to summarize, sir, the main crux of these two case presentations is to the audience is, of course, taking the proper semiology is one thing, and concordance with electroclinical by video EEG. Take the help of functional imaging or, of course, 3 Tesla MRI and all. That's all you've done for pre-surgically with taking help of neuropsychological assessment. If you take the money case, you've done proper evaluation, concordance, but patient is not responding after post-surgically, even the precise surgery. The reason being one is pathology. Apart from pathology based upon report, which thing we found is these pathology sometimes associated with some genetic mutations, especially this case. These cases, sometimes they open the new concept of D-galactose supplementation, paragalactose, can improve the patient's outcome in surgery. So in patients with lesions, even though they do surgery, they're not responding. They have some metabolic factors which are operating, which also leads to epileptogenesis, not only refractory epilepsy, even epileptic encephalopathies with cognitive development. So, of course, we didn't try for this genetic estimation for this patient. We are planning for it. And they suggest that D-galactose supplementation sometimes may show some improvement in this case, where already failed surgery is the one indication despite proper localization. That is the first case. Second case, if you take proper localization has gone to the insular area with reflex epilepsy, but if you take the patient has MTS also. But whenever you see drug-resistant epilepsy, whoever sees MTS, they're always inclined to go and do the temporal lobectomy. That is a wrong concept. Because in this case, the more reflexogenic area, epileptogenic area, most goes to the insular gliosis. So properly locating the lesion, which is responsible for distractible seizures, is the insular cortex. If you try to remove it, there's go the more rewarding results rather. So proper localization, removal of the surgery also will give you the post-operative results. So here MTS is secondary, pertain to the secondary to the gliosis factor in the peri-insular area. So location, selection of the patient, and proper operative procedures will only give the good seizure-free periods. Thank you, sir.
All of you are aware of the GLUT1. Similarly, this is a galactose 1 transporter, no?
Yes, yes, sir.
The
Yes.
glucose transporter and a galactose transporter.
But
Good.
gene mutations.
A very good learning message.
Very good.
Thank you so much, Dr. Sindhu.
Thank you, sir.
And I'm sure that the entire crowd enjoyed a intellectual bonanza. I'm very, very happy. All the cases today presented were excellent, and I thank both the teams. Fantastic. Sir, Professor Sudhisha, sir, anything to add, sir?
We must compliment both the institute and both the head of departments for elevating the levels of the learning and teaching, and as far and look at the level that they have gone into, not only just localization, concordance, and but they are going to the genetic level, metabolic level, networking, and other disruptive pathways which are problematic, and all these things. So, in fact, our learning about epilepsy, epilepsy surgery, the outcomes is ever expanding. And I'm very happy that Sampath is doing a great job at his place.
Yes, sir.
And Madam Radha is also doing excellent work. And at a personal note, I had the privilege of giving the prize of TISA winner to ma'am in, I think, 2008. So she has been bright from her student days. So these are my old memories of Ahmedabad when she came here as a student. So, Dr. Lakshmi, you must celebrate today's day, the landmark
Yes, sir.
day, the 60th episode, and say a few
Yes,
words,
sir.
and then we close
Yes.
it down. And we must thank enough to Mr. Chadda
Yes,
and
sir.
his team for this
Thank you.
wonderful
Thank you,
webinar
sir.
series. Yeah.
Thank you.
So thank you, Sudhir sir. Thank you, Lakshmi sir.
Thank you, sir. Thanks a
Thank you,
lot for the
Thank you.
opportunity given, sir.
We thank you for giving us such
Thank
a
you, sir.
wonderful.
Thanks a lot.
Thank you,
It's a
thank you,
nice
thank you,
opportunity,
Thank
sir.
Thank you, Intos, sir.
Thank you for the opportunity.
Thank you.
Thank
Thank
you,
you,
sir.
Dr. Anush.
Thanks a lot.
Thank
Thank
you
you,
so
sir.
much.
Thank you.
Thank you, sir.
With this, tonight's session have truly been a feast of knowledge from Government Kilpauk Medical College, Chennai. Dr. Zerom's thoughtful case presentation, Dr. Anne Morgan Pandian's insightful discussion, and the concluding perspective of Dr. Radha Ma'am have deepened our understanding of rapid cognitive decline. Equally enlightening was the session from Narayana Medical College, Nellore, where Dr. Arishta and Dr. Lipika detailed case presentation, Dr. Anusha's clear discussion, and the concluding remarks by Dr. Sampath Kumar sir shed new light on the challenging domain of drug-resistant epilepsy. With episode 60 and 61, Secrets of Neurology proudly completed 5 years of academic excellence and knowledge sharing. Our heartfelt gratitude goes to our course directors, Dr. Sudhir V. Shah sir and Dr. R. Lakshmi Narasimhan sir, whose vision and leadership have sustained this remarkable journey. We hope every participant take home fresh insight and renewed inspirations to apply in their clinical practice. With this, we formally conclude episode 60 and 61 of Secrets of Neurology. Looking forward to meeting you all in the upcoming session scheduled on 27 September 2025. Thank you so much, sir.
Thank you.
Thank you. Thanks a lot, man.
Thank you.
Thank you so much, Sudhi sir.
Thank
Thank
you,
you,
ma'am.
Radha ma'am. Thank you, Sampath sir.
Thank you.
No,
Thanks a lot, sir.
Shweta. And of course, thanks to both the all the students who presented here.
Thank you. Thank you.
Thank you, sir. Thanks a lot.
Good night.
Thanks.
Thank you, sir.
Support?
Yes.